Well, it's good to see some faces, and it is just about 3 o'clock, so it's all right. I'd like to go ahead and start this meeting. Victoria, it's great to see your face. It's been a little while. We used to serve in committee together, and she would sit next to me. She was my buddy. We'd pass snacks to each other. Can't do that here virtually. But anyway, I'd like to go ahead and call to order our statewide substance use working group subcommittee. It's our subcommittee number 3, focusing on response. And with that, I'd like to ask for a roll call to see if we have a quorum.
No, about that.
Let me go to our list. Do you want me to call that?
Yes, please.
Chair Assemblywoman Jill Tolles.
Here.
Christine Payson.
Here.
Dr. Stephanie Woodard.
I'm here.
Dr. Terry Kearns.
Present.
Shayla Holmes.
Present.
Gina Flores O'Toole.
Present.
Thank you. And we do have a quorum.
Wonderful. Thank you so much. And thank you all for joining on our first subcommittee meeting and for doing it in such quick turnaround from our last working group. So the next item on the agenda is to open up for public comment. And so if there's anybody, let's start with whoever is on Zoom. If anyone is on Zoom who would like to give public comment, we'll give you each up to 3 minutes of public comment. And go ahead and raise your hand, and I'll let Crystal unmute you or acknowledge. Do we see anyone here? No?
I don't see any raised hands, but anyone is welcome to start if they did want to make public comment.
If it's appropriate and okay, I know that we have some non-members that are listening in. Would love to take this time during public comment if you just want to introduce yourself and the organization that you represent. We'll start with you, Jeanette.
Good afternoon, Jeanette Belts, Belts Case Government Affairs on behalf of the Nevada Psychiatric Association. Thank you.
Thank you. And Leah, if you can hear me and unmute, introduce yourself.
Good afternoon. I'm Leah Tauken with the Abney Tauken Group, and we are representing the Recovery Advocacy Project.
Excellent. Thank you. And Mary Sarah.
Good afternoon, Assemblywoman Mary Sarah Kinner, representing the Washoe County Sheriff's Office.
Yes. Oh, thank you.
Thank you.
Anyone else that would like to introduce themselves? Madeline.
Hi, everyone. I'm Madeline, or Maddie. I'm with the Masters of Public Health at UNR.
Fantastic. Thanks for joining us. And I know we have some presenters that we'll hear from later. Anyone else that's joining us? Okay. And do we have anyone who's called in for public comment on the phone? No? Okay. Well, with that, we'll close public comment and move on to agenda item number 3, member introductions, subcommittee roles and duties, and working group updates. And so I'll start with myself. We've had a chance to do this in the working group, but for anybody who's watching or anyone who's new who's joining us, I'm Jill Tolles. I'm Assemblywoman for Assembly District 25 and Vice Chair of the Substance Use Working Group. This came out of legislation that was passed in the last legislative session, the 81st legislative session, AB 374, which I had the privilege of sponsoring and receiving input from many who are on this call. And I am thrilled to be able to work on this. On a personal note, I too have been touched by these issues, and this was extremely meaningful for me to be able to pass this legislation and continue to work on its implementation. And another personal note, just coming from the university campus and finishing up teaching a course there and having just a 15-minute conversation with a student who was really struggling and has had a difficult time through this semester, but is an incredibly bright student, and needed just that extra little touch to sit down with and check in. And through the course of that conversation, learning that he too was in recovery, it just reminded me of how far-reaching this issue is, how incredibly important it is, how incredibly difficult these last couple years have been, in particular around this issue, and why we're doing this work that we're doing. And so I'm personally extremely grateful for this group and grateful for you taking the time to help us come up with solutions for students like the one that I just spent time with, who just needs people to care and wrap around them to get them on the road to recovery, and to make sure that we're responding as a community in effective ways. So that's a little bit of my background and some of my passion for this topic. And then specifically this working group subcommittee, we will be talking about the roles and responsibilities, as well as some of the topics we're going to be focusing on. But having served 2 terms on the Judiciary Committee, I know that judiciary issues are particularly pertinent to this topic, as well as being a business owner in downtown and recognizing for our properties downtown the impact that oftentimes this has on our economy, on our community, on issues like homelessness, on tourism, and then just also having had somebody, having been a guardian for somebody in the system in the past, and knowing how important this is, dealing with foster care and all the community and family impacts that we'll be addressing in this subcommittee. I'm really looking forward to the pooled resources of each of the members here. So with that, I'd like to go around to invite the other members. Christine Payson, if you'd like to start, and from the Sheriff and Chiefs Association, just reintroduce yourself and maybe tell us a little bit more about yourself and your focus on this committee in particular.
Thank you. My background is law enforcement. I did 21 years with Las Vegas Metro and retired as a sergeant out of there before going to work for Nevada HIDTA, or the High Intensity Drug Trafficking Area, as a training coordinator. So bringing in various types of training for the officers, both in Clark County and up in Reno. Those are our 2 HIDTA areas. And at the same time, I was a prevention coordinator, so I started to work closely with some of the coalition folks, again, both in the South and up in the North, and learning, getting a complete 180 from a law enforcement background and mindset to learn about things like medically assisted treatment and harm reduction strategies. So it was quite an education and quite a shift that I had to make. But like probably everyone here, I have personal experience with a family member. Sorry. So when he was brought back from Narcan twice, I have a whole new respect for harm reduction and medically assisted treatment, which he is now in and doing well. So I'm grateful for that. And I shifted over to drug intelligence officer after doing training coordinator and prevention for 4 years once we were funded for that. So because I had those relationships with public health and coalitions and those wonderful people that I could partner with, the shift to drug intelligence officer was pretty easy for me. And I'm now paired with Lacey Alderson, who's our public health analyst, and our whole strategy for the overdose response strategy funded by ONDCP is how do we match up public health and public safety and address the overdose problem. So that's my position now, and that's why they decided that I should be their representative for the sheriffs and chiefs, because of both the law enforcement and now a prevention and overdose response strategy background. So I'm happy to be here. Kind of drinking from the fire hose when it comes to reading all of this legislation. I never did any time in intergovernmental affairs, but I'm doing my best, and I'm happy to be part of the team.
Thank you, Christine. We're extremely grateful for your experience, and thanks for sharing your story and recognizing that how to see the whole picture. It's incredibly invaluable to get your voice at this table. So thank you. And Dr. Stephanie Woodard, who I have to give credit to, was very integrally involved with helping to craft this legislation, along with, and I also have to give credit to Jeanette Bells. I know she's not officially a member on this subcommittee, but was also very, very engaged in the crafting, and Christine Jones Brady from the AG's office. So Dr. Woodard, with that, can you share a little bit? I know your reputation precedes you, but share just a little bit more on this side of the subcommittee.
Sure. So Stephanie Woodard, I am a licensed psychologist and serve as the single state authority on substance abuse treatment and prevention, as well as the state mental health authority. I've been working in the world of co-occurring disorders with a specific focus on co-occurring disorders in the maternal population. So worked a lot with moms who had mental health as well as substance use disorder issues, and lots of work with moms and babies and kids in a prenatal to 5 program back when I was doing some of my pre-doc work. So the area of addiction treatment and its intersection with mental health is something that I have spent my career working on. And as it relates specifically to substance use disorder and the intersections with the criminal justice system, as well as the other topics that will be tackled by the response subcommittee, have helped in crafting legislation over the last several sessions, including Assembly Bill 474, which specifically addressed things like prescribing for controlled substances, have also helped to orchestrate the 2 opioid summits and the governor's subcommittee or task force on opioids. Really have been working in this world for quite some time. Lots of experience in working with law enforcement as well as public health, and actually was able to develop the position that our next member will be discussing, Terry Kearns, specifically to make sure that we have a connection between law enforcement and public health. So really excited to be part of this initiative. And Chair, I'll turn it back to you.
Fantastic. Thank you so much. And Dr. Terry Kearns, with that, we'll pass the baton to you.
Great, thank you. As Dr. Woodard said, my name is Terry Kearns. My position physically is located in the Attorney General's office, but is grant funded out of funding from Department of Health and Human Services here in the state. And the idea behind my position is to try to bring the efforts of law enforcement, first responders, public health, and healthcare moving in the same direction. I previously was a registered nurse for 11 years, and then from there went into federal law enforcement and retired out of that after 21 years of service. So realizing that oftentimes you see the intersection of public health and law enforcement and first responders, but sometimes it's not always as smooth. They kind of speak their own separate languages. So trying to bring all of those efforts working together, and so they understand each other a little more.
Thank you. I appreciate hearing both of those sides, that theme of public health and public safety. All right, and Shayla Holmes.
Thank you. Shayla Holmes. I am the current Director of Human Services for Lyon County. As many of you may have seen on the needs assessment data that's been presented thus far, Lyon County certainly has some significant impact from the opioid crisis. Prior to my directorship, I've worked with children and families, particularly on the maternal and early childhood side through our home visiting and WIC programs. I've also spent many years working with our senior population through case management, senior services, and a variety of different home-based services for our older adults. One thing that I think is critical when we look at opioids from a community response is really how we do this without stigma, because many of our older adults utilize opioids as a quality of life factor. And I would really like us to consider what individuals that have made this a part of their life and how they maintain with these drugs in their life, and how we help them and wrap services around them, because it is a totally different perspective when you go into the home of a 20-year opioid prescribee and start working with them and what those impacts are to them. Personally, I think probably like everybody on this call and anybody working in this field, I have had personal loss to substance use disorders, and I've seen a niece of mine actually come back to life utilizing naloxone and having to be rushed to EMS from a bad pill out in Douglas County. So I think really everyone in our communities are impacted, whether it be an older adult being prescribed or being a young youth in our communities experimenting, and how we wrap services and how we work with all of the different spectrum of our populations is different. I'm anxious to get to the outcomes for our communities where they exist without stigma as far as the services needed and how we can help them get connected to the right service for them. On a educational side, I am a doctoral student through Westchester University, and I am working on my doctorate of public administration, and my dissertation work is really around building socially equitable communities. And I think that this is absolutely aligned with what those goals of my educational work is as well. Thank you.
We appreciate your academic expertise as well as your practical experience and personal experience as well. Thanks, Sheila. And so next, Gina Flores-O'Toole.
Hi, thank you. I am the executive director at Ridge House. It's a new position for me, so I'm still learning a lot. I have a lot of experience in treatment. I worked at West Hills for 9 years. I've been here for a couple of years. I was at Alta Vista for a little while. So I'm representing the treatment providers. I have had personal and family experience with opiates, and my brother committed suicide using drugs. And so there's, a lot of personal meaning here. So excited to get to work.
Thank you so much for sharing, and I'm sorry for your loss, and thank you for using it for good for others to help prevent this for other families. And then we have an incredible team who is helping to support us from SEI. So if we could just really briefly introduce them, because I know that we would not look nearly as organized if it wasn't for all of their help and support. So Crystal Dward, if you would like to introduce yourself briefly.
Hello, I'm Crystal Duarte. I'm with SEI, as Chair Toll said. Just here to support. So you'll see a lot of emails from me and possibly another team member, Deanna Lyons, who helps us do some of our scheduling. So when you see those emails come through, we really appreciate it. And thank you for rallying together to be here on this meeting.
Absolutely. Thank you. Thanks for all the help. And then Laura Hale, who, yeah, there she is.
Hi, thank you. Also providing support. So you may see my name on some materials as well. So,
and also making sure that I stay compliant. As many of you know, we don't have to follow the open meeting law in the legislature. So this is all new, and you have full permission to interrupt me and make sure that I'm staying on on track. All right, well, with that, I'd like to just move on if we can. And I know that we have some slides to share in regards to just reminding us what this committee's scope is, not just for us as members, to keep this in the forefront of our minds in this work, but also to make sure that the public is aware, anyone who's tuning in and watching this. So the response subcommittee will recommend strategies to improve coordination between local, state, and federal law enforcement. and public health agencies with representation from those different agencies, and information sharing regarding trafficking and distribution of legal and illegal substances will be reviewed. So we talked a little bit about that public safety piece, and then the intersection with public health. And that would definitely be on the side of public safety. And I know Christine Payson had made some comments to that in a prior working group meeting, that we do make sure that we're tackling that side of it. And then the effects of substance use disorders on the criminal justice system will include a deep dive into the sources and manufacturers of substances and the effectiveness of criminal and civil penalties, with attention to shared responsibility. And later we're going to be hearing from the Sentencing Commission that has also done a great deal of work in this, and we hope to not replicate or reinvent the wheel, but to continue to collaborate, breaking down those silos and building off of the work that has been done to help support it into action. And then the next slide, please. A response subcommittee is tasked with making progress to evaluate ways to improve and expand evidence-based or evidence-informed programs, procedures, and strategies to treat and support recovery from opioid use disorder and any co-occurring substance use disorder, including without limitation among members of special populations. And so one of the things that was extremely important in the development of this legislation was to make sure that we always had in the backdrop the impacts on special populations, ones that are particularly vulnerable. We want to look at this impact on every citizen in every community. And we also want to see where the gaps are and make sure that we're inclusive in our analysis. And we're also tasked with recommending strategies to improve coordination between local, state, and federal law enforcement and public health agencies, that public safety, public health nexus, to enhance the communication of timely and relevant information relating to substance use and reduce duplicative data collection and research. Again, one of the reasons why we have the Sentencing Commission here to help to give us some status updates, and we'll continue to hear from in future meetings our local law enforcement and different jurisdictions and at the county and city level. We're also tasked with evaluating current systems for sharing information between agencies regarding the trafficking and distribution of legal and illegal substances, which are associated with substance use disorders, including without limitation heroin, other synthetic and non-synthetic opioids and stimulants. And then studying the effects of substance use disorders in the criminal justice system, including without limitation law enforcement agencies and correctional institutions, and studying the sources and manufacturers of substances which are associated with substance use disorders, including without limitation heroin, other synthetic and non-synthetic opioids and stimulants, methods and resources for preventing the manufacture, trafficking, and sale of such substances. And just again, the importance of this is not limited to only opioids, but broadening the scale to all substances. And then studying the effectiveness of criminal, civil penalties at preventing the misuse of substance and substance use disorders and the manufacture, trafficking, and sale of substances which are used with substance use disorders, including without limitation heroin, their synthetic and non-synthetic opioids and stimulants. Next slide. And then with that shared responsibility to always have before us assessing evidence-based strategies for preventing substance use and intervening to stop substance use, including the heroin and other synthetic and non-synthetic, and examining qualitative and quantitative data to understand the risk factors that contribute to use and rates of use disorders, focusing on special populations, and then finally studying, evaluating, and making recommendations to the Department of Health and Human Services concerning the use of money described in section 10.5 of the Act. And we'll be talking about that update here shortly. And then the committee's scope, we wanted to make sure that in all of our subcommittees, we're keeping in mind the special populations. So as we have these discussions, we want to make sure that we are bringing in how is this affecting veterans, elderly persons, and youth, and particularly vulnerable populations, persons who are incarcerated or have committed nonviolent crimes and driven by substance use disorder, pregnant women and parents of dependent children, LGBTQ communities, persons and people who inject drugs, children who are involved with the child welfare system and any other populations that are disproportionately impacted. And our roles are to attend. So thank you all for successfully creating a quorum on our first meeting together. And then if you cannot make it, please do communicate with myself or with Laura or Crystal to make sure that we can be aware of how many we need to ensure that we have a quorum, or we can schedule around your needs, and then provide recommendations in advance of the meeting. So this is really where the meat of the work is. We will be reviewing materials and discussing presentations by subject matter experts for the sake of making recommendations, so that we can make recommendations around bill draft requests if it requires a policy change, around any budgetary items if it requires federal, state funding or use of the opioid settlement dollars, or any other gifts and grants for programs and for services, and then any other action that can be taken, for example, public outreach or changes in recommendations to internal policies in the Department of Corrections, for example, or in child welfare systems, or other programs that we can recommend to increase community public safety and public health. So next slide, please. So just to lay out a roadmap of what we have to expect moving forward, we've already had 2 meetings with the Substance Use Working Group as a whole. The subcommittees are expected to meet monthly, and I'll be chairing, and then we'll have targeted administration. Again, we're going to be bringing in subject matter experts from Nevada as well as nationally to help ensure that we break down the silos between any jurisdictions in our state, understanding where some of the gaps are, what is already being done, what's effective, and how we can better coordinate between them. And then also bringing in subject matter experts in the state and out of the state to look at best evidence-based practices. And so we also have a timeline that we're working toward with specific goals. Our membership is expected to be 1 year beginning March of 2022. So we're already 1 month into it, and extending to February 2023. And some of the milestones that we have to look forward to is in March, we had the DHHS needs assessment update and announced the members of this committee. June, we're working towards presenting a subcommittee progress report and presentations based on the subject matter expert presentations we've had and any initial recommendations that we've developed thus far. September, we will present our subcommittee recommendations, excuse my dog in the background, on our report, and then discussion as a whole working group. We're going to be doing that for the purpose of, again, making those BDR requests if we have any that we would like to get some sponsorship for the next legislative session, any budget recommendations for the use of these dollars as they're coming in, and any future use of dollars. And then as a group, we will vote on those recommendations and then present a final report in next January on our working group as a whole. And that will be an annual schedule that, for as long as members are a part of this committee and this working group, will be following now and in the future. And I want to point out that we don't have to tackle everything all at once. Part of this job of this subcommittee will be to gather information and to prioritize what we want to present as our best recommendations, our most immediate needs, and that we want to address first. So if we can move to the next slide. So one of the tools that I recommended that we use, I've used this in the past with 2 separate task forces that I've been involved with on school safety and sexual abuse prevention, is that to help keep us all on track and to keep the discussion moving forward in a timely manner and an efficient way, we're going to utilize a spreadsheet, which everyone will get an Excel spreadsheet. And you'll see that you'll be able to put your name in there as the sponsoring member of any recommendation. You'll have an opportunity to explain your recommendation and any requirements that we're meeting with that recommendation as outlined by the statute from AB 374. And then any other cross-cutting elements regarding special populations that we are addressing, or any other requirements from the legislation. And then our justification, this is where you get to give us your best selling points, and any research links. This is where you get to back it up with your citation of sources of where this evidence-based best practice came from, maybe something that we heard from the subject matter experts, and what action step this would fall into. Is it a BDR? Is it a budget request? Is it some other action? Is this a short-term or a long-term solution? In other words, if it's a statutory change, obviously we'd like it to be well-written and permanent, or will it be something that is, more temporary in nature, like a monthly campaign, outreach campaign, public service announcements, and so forth? And then does it have a fiscal note? And then you'll have an area where members can write down their comments and feedback, where during the discussion or to help prep for the discussion, we'll be able to review other people's recommendations and write in our member feedback so that we can move the discussion along in our working group. And urgency and impact, that can help with the prioritization piece. And again, we're going to be using this as a tool to get us towards that June deadline of our first update, and then the September deadline of our actual recommendations that we'll be formally presenting to the working group to vote on. We'll move to the next slide.
Madam Chair, if it's okay, we as an internal team had a question for the group. We were wondering if it would be easier to submit this information via a survey link than Excel. So if anybody has a comment on that, we would be interested in understanding in terms of ease of use, if anybody has a preference.
Yeah, if you want to go ahead and raise your hand or just unmute and speak up. I'm going to pull you back on the screen so that I can see you. All right, how about a raise of hands? We'll do a quick tally vote. Raise of hands if you prefer just being given an Excel spreadsheet. All right, and then raise, so I've got Dr. Terry Kearns prefers the Excel spreadsheet. So just to confirm that everybody's participating, and here's the question, raise your hand if you would prefer it to be in a survey form for the subcommittee members. Okay, so we've got 2 who prefer the, okay, and then who have we not heard from?
I don't seem to have a hand raise feature on my work computer. This is Christine, but not going to lie, a survey would probably be easier than a spreadsheet for me, but I'll power through either way.
All right, and then Shayla, and Shayla has her hand raised as well. Okay, so it looks like we've got a majority rules here that we prefer a survey form. And are you okay with the Excel spreadsheet by way of presenting the information after we gather it? Go ahead and just nod your head or give me a thumbs up. Great, okay. So Crystal, does that work for you then? We'll send it out in a survey form and then we'll present it in the meetings in the results in either Excel spreadsheet, or we can talk about other ways to put it into a chart in a slide presentation.
Absolutely, that works for us. And during our meetings, you would still have time to comment on other people's suggestions and recommendations. And so that's why it's important to review things before our meetings. But we'll get that out to you so you can see everyone's recommendations prior to meetings.
Okay, sounds good. Well, thanks for that question. Sounds like the members appreciate it too. And we'll move on from there. Was there any other, let's see, back to my Okay, so we actually, I jumped ahead. I moved from number 3, the introductions, roles, duties, and working group updates to the recommendation tracking tool. And so we just combined those agenda items 3 and 4. And if we can go ahead with, unless anybody has any questions or comments, move on to agenda item number 5, which is Dr. Stephanie Woodard to jump in with an update on a review of baseline information for the substance use subcommittee. Thanks.
Thank you, Chair. So we probably don't need to do Stephanie Woodard for the record, but I will, just because I think it's good decorum. So my understanding of what my role here today is to provide some baseline information for the subcommittee, knowing that we've got lots of people that are coming from different sectors to just provide some level setting and some, kind of basic information. But when SEI and I were preparing for this, I'd rather have this be a discussion because there are likely going to be questions that come up as I go through some of this material. And I think that it would be beneficial, instead of waiting until the end, if we can use this as really more of an opportunity to dialogue. There will be issues that I'll be talking about that have to do directly with our treatment delivery system, for example, and we have a provider on our subcommittee that likely would be able to provide some additional information. Similarly, I'll be talking about some topics that other committee members likely also have quite a bit of information and expertise in. So the more that we can kind of use this as some dialogue, I think the more that collectively we will all get out of this. So the only thing that I ask is that we have some way to monitor the time, because it's very easy with some of these meaty topics to, I think, go down some meaningful conversation roads, but want to make sure that we use the allotted time necessarily. So I think, Crystal, is that something that you might be able to do, is just monitor some time for us?
She seems to be frozen, but I'll be happy to monitor that. Oh, here she comes.
Okay.
Yeah, we have about 30 minutes for this presentation, so we'll try to wrap up close to 4:05, if that works.
Okay, that sounds great. All right, so just a brief overview of DPDH prevention and treatment programs. I actually have a copy of our most recent SAMHSA substance use prevention and treatment block grant application that I can provide to this group. It has a ton of additional information in it as to what the current structure of our prevention and treatment programs look like. But I will just touch on some of those basic concepts here. So as it relates to prevention, the Substance Abuse Mental Health Services Agency for a very long time has really wanted states to focus primarily on primary prevention. In primary prevention, there are 6 primary strategies that are used to classify those primary prevention activities. And those include information dissemination, education, alternative programs, so programming such as school dances, recreational activities within a community that do not involve alcohol or drugs, problem identification. So if a youth is identified as potentially having use with substances, that they can be navigated to education and resources, community-based processing, as well as environmental strategies. So these 6 core activity areas really do guide the way that our prevention coalitions identify the ways that they will deliver prevention programming as it relates to substance use in our communities. And we have 10 funded coalitions across the state. Each coalition covers a specific region. And we have also begun working with the coalitions as well as our data analytics teams to make sure that coalitions have the necessary data for the regions that their coalitions cover. We also have advisory groups that specifically focus on prevention, and those include our state epidemiological work group, as well as our multidisciplinary planning committee. What happens is there's epidemiological data that is collected and reported through the SO, and then that data is then introduced to what we call the MPAC. And the MPAC then looks at the data and helps to identify specific areas of focus that really is grounded in the qualitative and quantitative data. The prevention coalitions do a ton of work in their communities, not just substance use disorder prevention or substance use prevention. In many communities, those coalitions are also doing active programming in the schools, suicide prevention, and really do serve as a community hub for a range of information. Within prevention as well, we have some core funding streams. The vast majority are federal funds, but we do have a small allocation of general fund dollars that are also allocated for prevention. Prevention coalitions do quite a bit of environmental assessment within their communities to develop their prevention plans. And so it really is a partnership between the coalitions as well as the state and those advisory committees to develop comprehensive prevention programming statewide, but that is also uniquely tailored to each community. On the treatment side, we have a SAPTA advisory group. So SAPTA is an abbreviation that stands for the Substance Abuse Treatment and Prevention Agency. SAPTA sits within the Bureau of Behavioral Health, Wellness, and Prevention. And the SAPTA Advisory Board does exactly that. It advises the agency within the Bureau on all things substance use disorder programming related, but also reviews policies, procedures, and what we call division criteria that help to guide us in treatment and prevention. We also have regional behavioral health policy boards. Many of you may be familiar with the regional behavioral health policy boards that cover each of the 5 regions. We also fund the regional behavioral health coordinators that help to coordinate those boards, but then also do a lot of work on the ground in the community, bringing organizations and providers together to have meaningful discussion, but also intervention as it relates to behavioral health. If you're interested to know about the organizations that we certify as either a prevention coalition or as a behavioral health provider, you can find them on a website. It's called behavioralhealthnv.org. When Medicaid expanded services to include substance use disorder treatment, they require through policy that all substance use disorder treatment agencies must be certified by SAPTA in order for them to be able to participate as an enrolled provider in the Medicaid program. So we work with organizations, provider organizations across the state towards certification. We work with CASAT, so the Center for Substance Abuse Technologies at the University of Nevada, Reno, who is our contracted vendor who supports us in doing the certifications directly for provider organizations. So we certify programs based on the American Society of Addiction Medicine criteria, which is it's very clear and detailed criteria that helps us to differentiate levels of care across the spectrum, everything from early intervention to withdrawal management in hospital-based and specialty clinic settings. So programs are required to be certified and continue with that certification process ongoing in order for them to be able to receive either funding through the Bureau or to enroll as a Medicaid provider. We use ASAM criteria because it is considered the gold standard and is actually a relatively rigorous process that provider organizations need to go through on the substance use disorder side to make sure that they meet those qualifications and continue to meet those qualifications. So I know Gina is at Ridge House, so she likely has some input that she may want to share around what that certification process looks like. So Gina, do you want to say anything about the certification process as you've seen it through Ridge House?
That's the unfortunate part, that I haven't actually seen a certification since I'm new to I'm the interim executive director. I do understand the ASAM criteria though, and I agree about the rigorous nature of it. We hold that to every client that we serve. The SAPTA staff have been extremely helpful in answering questions, helping us get through some bumps in the road, and so for that I'm very grateful. So thank you.
Thank you. So a little bit more about our certification, because I think a lot of people don't really know what goes into our certification. So not only do we certify by ASAM levels of care, so outpatient, intensive outpatient, partial hospitalization, and then residential treatment programs, as well as withdrawal management programs. We also certify our opioid treatment programs, so our OTPs, also known traditionally as methadone clinics. Early on, as we started receiving state targeted response grant dollars, we actually started to build out that program and developed an additional designation of our integrated opioid treatment and recovery service providers. These providers expanded access to things like psychiatry for individuals with co-occurring disorders, peer recovery support, and also provide some crisis services for individuals who have experienced a non-fatal overdose. In addition to that, we also separately certify programs as it relates to adolescent substance use disorder treatment. And we have programs that we certify for civil protective custody, which I'll talk about a little bit more extensively in some of the next slides. Co-occurring disorder treatment. So there is an endorsement that programs can receive as it relates to how co-occurring capable they are. We worked with Dartmouth University several years ago to bring in a tool that we use to be able to determine how co-occurring capable programs are. We also certify drug court services, evaluation centers, as well as transitional housing programs. Does anybody have any questions thus far before I continue? There's just a little bit more that I want to talk about as it relates to treatment, and then I'll move on.
Dr. Woodard, I just want to make sure, thank you, that the slide that we've been seeing this entire time where you've been talking has just been the same slide, the overview of DPBH prevention. Okay, I thought so, but I just wanted to make sure.
Yes, which is why I think being able to provide the grant application so that you can see the narrative where there's a lot more information available would be very helpful for this committee, because I do think that it just serves as some baseline information that could be helpful.
Great, thank you. I don't have any more questions. Does anybody else have any questions for Dr. Woodard so far? Okay.
Okay. So as we move into some of the issues as it relates to the response subcommittee, and Crystal, if you want to just move ahead in the next slide. One of the primary areas that we have been focused on and have created a lot of funding opportunities for community providers and organizations, as well as courts over the last several years, has been on the entire sequential intercept model. So about 50% of individuals that are receiving services that are either state general fund funded or federal funded through the Bureau of Behavioral Health, Wellness, and Prevention are actually referrals through the criminal justice system. This is incredibly important because we realize that it's actually the majority of our certified and sometimes certified and funded providers that really are working hand in hand with the criminal justice system in order to make sure that we are providing and individuals are receiving the substance use disorder treatment that they need to remain in compliance with drug court, for example. So there is this inherent partnership that is occurring with the Bureau, as well as treatment providers, and then with the entire criminal justice system. So much so that back in 2018, through our behavioral health community integration plan, we actually identified both juvenile justice diversion and criminal justice diversion as two primary priorities, which has since guided the prioritization of some of our funding. So as I go through these slides, I'll be talking about some of the programs that we have funded. And I will say just right now that none of them are to scale. We've got some really amazing sort of demonstration projects that are occurring in different regions statewide, but there's not uniformity across all of the communities as it relates to the access to some of these programs. And we also don't necessarily have providers in each of these communities that are actively engaged in providing some of this programming. So data and information sharing. As we were constructing this legislation, we really wanted to take this as an opportunity to have some discussions around data and information sharing, because it has been an area of limitation for as long as I've been working in this area. And when we talk about data and information sharing, we're typically talking about law enforcement and public health or behavioral health information and data sharing. So helping to understand what information can be shared to whom, under what circumstances, rules around redisclosure and the like. It is in the absence of information and data sharing that we find that we have some of our greatest risk, because as there are substances that are confiscated in some of our communities, and if those drugs can be tested, knowing what is in our community is vitally important for our public health and healthcare system to know, especially if we have something like what is commonly referred to as a bad batch. So especially with the proliferation of fentanyl and fentanyl being tainted in a number of different drugs, ensuring that not only do we have the opportunity to communicate that to public health officials who may be on the response side, but also getting messaging down to individuals who use drugs so that they can also be informed around what they may be seeing in the drug supply, we think is a critical component to helping to keep individuals safe, even as they continue to use drugs as part of a comprehensive harm reduction strategy. So we certainly in our state have a number of assets available to us, including the high intensity drug trafficking program, our overdose to action grant, which has just done a phenomenal job in increasing the level of surveillance data that we have available to us. And that surveillance data is essential in combination with the ODMAP program that I'm sure Dr. Kearns can speak to in just a moment, so that we do have quantitative data that can help us detect when there are changes in some of our overdose trends in our state. It allows us to do what we would consider, listening to what is occurring, so that if there is a spike that occurs, we can put our spike plans into action. Through our state targeted response grant funding, we actually worked with communities across the state to help to develop overdose spike response plans. So each county now currently has an overdose spike response plan that talks about both pre-event, during event, and post-event, and what could occur and who's responsible for doing what should a spike be detected. There are gaps and some recommendations, including the ability to utilize some of our technology. So the prescription drug monitoring program, there have been lots of conversations about how we can optimize the PDMP for additional communication. The need for the health information exchange, Nevada has an HIE, however, it is woefully underutilized and really is sort of the conduit for some information and data sharing, at least among healthcare providers, and then adopting a registry. So we currently do not have a patient registry for our opioid treatment programs. This has been something that has been a priority of ours for quite some time, and we're hoping to be able to move forward with being able to fund one. But a registry essentially allows an opioid treatment program, when an individual enrolls with that program, to ensure they're not receiving similar services at another program within our state. You can imagine how important this would be to reduce the opportunities for multiple registrations with multiple providers for individuals that are being prescribed and dispensed methadone. Also, opportunities to analyze data to help to understand where resources are needed, as well as early intervention when there are trends that we are tracking that demonstrate that there is a need for additional resource to be targeted to specific geographic areas as well as populations. And then opportunities to develop those policies and procedures to be able to share data, such as MOUs, so that we do understand how information can be shared across entities, under what circumstances, issues around disclosure and redisclosure and the like. But we're blessed to have Dr. Kearns with us on our subcommittee, and she has been instrumental in helping to launch the ODMAP program. So Dr. Kearns, I'm wondering if you would be able to just speak a little bit about ODMAP for the committee so that they understand what it is and what the purpose is.
Sure, sorry about that. It took me a minute to get off of mute. Yes.
Quickly, excuse me, Dr. Kearns, before you start and take that baton away, I just wanted to point out that it's 3:58. So I know that Dr. Woodard, you were interested in looking at time. And so I definitely want to hear from Dr. Kearns, but I do know that you have about 4 more slides as well to take a look at.
No problem. I'll quickly go through ODMAP. ODMAP is an acronym for the Overdose Data Mapping Application Program. It's a free program to us from the HIDA out of Washington, D.C., Baltimore. And the idea is that it's a pre-hospital surveillance tool that looks at suspected overdoses. So, and to try to look at real time. And I've come to find real time has different definitions. In this case, real time would be 24 to 72 hours to provide information on overdoses in a geographic area or a community, so that if we did see a spike, and in those overdose spike response plans that Dr. Woodard talked about, every community defined what a spike would be in their community. So if you see a spike, whether it's 2 or 6 or whatever it is, depending on the community, the ODMAP would alert to those from the pre-hospital setting, and then also allow that overdose spike response plan to go into place. Currently, what we're using in the state is an API, automated program interface, from the state EMS database, and then that goes into ODMAP. There are a few states throughout the country who law enforcement does this function, and there is a component of ODMAP that does a lot law enforcement information. So say, for example, law enforcement went out and it was heroin they saw on scene. That's the kind of information that we're not getting in ODMAP. There is a place for that, but oftentimes EMS doesn't have that information. So there is more robustness with the system. I'm going to go over to HIDA tomorrow and work with one of the analysts, because there is a predictive analytic capability. So if you know your trafficking routes, you can look at counties. Let's say, for example, we think stuff's coming into Vegas from Phoenix. You could look at the county that Phoenix is in, and then also look at our county. And over time, if in using this, if you're starting to see spikes in overdoses in Phoenix, and you may, whatever the time frame is to get from Phoenix up to Vegas, you could start to predict that you may see overdoses based on those drug trafficking routes. So we're going to meet with HIDA to try to see if we can do some work on that aspect of ODMAP and take it to the next level. That's a quick thumbnail of ODMAP.
Thank you. Okay, so public health and law enforcement prevention and coordination, lots of assets in Nevada, including Opportunities for the sequential intercept model. The sequential intercept model really does describe opportunities for intervention from deflecting people away from the criminal justice system to how the criminal justice system can engage individuals who have behavioral health needs with treatment, regardless of whether it is within a formal criminal justice system, such as drug court, or through incarceration or reentry, or to support them in diverting from formal involvement with the criminal justice system. The crisis response system is a system that we are building as we speak, recognizing that individuals who are in a behavioral health crisis need support when and where they need that support, including 988. So the behavioral health crisis line, mobile crisis, as well as crisis stabilization, ensuring that people are evaluated very quickly and transferred to the most appropriate level of care where they need it. Certainly, again, high intensity drug trafficking, or HIDTA program, is an asset that we have. Relationships with federal agencies. As we talk about information and data sharing, we actually now have a partnership with DEA, CDC, and the FDA. So if there is an action taken from a federal standpoint within the state, they work closely with us within DHHS to notify us when that action is going to take place, so that we can come in alongside the community, so that we can help to lessen some of those impacts that can happen when an action is taken and a provider potentially taken offline and no longer is able to prescribe either MAT or controlled substances. The overdose response spike plans, naloxone distribution, as well as fentanyl test strips. Some great legislation last year that helped us move fentanyl testing strips out of the formal definition for drug paraphernalia. So now our harm reduction coalitions and others can distribute those within our communities. Remaining gaps and recommendations, again, data sharing across agencies, understanding the public health implications and outcomes of mixing various drugs together. There was actually just an alert sent out by the DEA today on the increase in fentanyl overdoses, because individuals are thinking that they're consuming cocaine and other stimulants, and those have been adulterated with fentanyl. So making sure that we've got that information and we're able to disseminate it to those who need it. Opportunities to expand harm reduction, distribution of naloxone, in the consideration of safe consumption sites. Definitely a dialogue that has occurred in the legislature in the past. And then prioritizing recommendations for funding the behavioral health field response grant program that was established within AB 236, so that we can ensure that not only when we have mobile crisis teams in communities, but also partnering with law enforcement so that they too can have a behavioral health response when they are working with individuals experiencing crisis in their communities. Next slide. Lots of gaps and recommendations as it relates to the criminal justice system. I know someone will be presenting on the Reinvestment Coordinating Council. So I'll move through some of this relatively quickly. Really the gaps and recommendations that we see is to potentially reevaluate our civil protective custody legislation. We've done quite a bit to modernize the language as it relates to our behavioral health crisis holds over the last 2 sessions. And it may be time for us to reevaluate civil protective custody legislation to ensure that people are getting to where they need to go when they are clearly in need of substance use disorder intervention from a crisis perspective. Also, potentially examining legislation and regulations that currently do have language in them that has been identified for many years at a national level as really criminalizing women who may use substances while pregnant. And it is that kind of language that continues to perpetuate a lot of the stigma, as well as a lot of the fear for pregnant women who have substance use disorders and actively engaging with treatment. Legislation to support diversion and deflection. There was recently model legislation that was presented as it relates to model deflection and diversion programs. So looking to see if there may be opportunities for us to formalize those kinds of programs in legislation. Include medication-assisted treatment, peers, social determinants of health, and harm reduction strategies in criminal justice system services, as well as promoting telehealth for medication-assisted treatment. Looking at policy considerations around essential services within incarcerated settings, be it jails or prison. There has been quite a bit of work at the federal level to very clearly articulate that access to mental health and substance use disorder services do meet the requirements for essential services that should be provided to everyone when they are incarcerated. And that includes having access to medication-assisted treatment. And there is new policy recommendations that are coming out that not only should medication-assisted treatment be used for withdrawal management while individuals are in an incarcerated setting, but it is a best practice to actually offer a continuation of that medication, both during incarceration and then following discharge, because we know that individuals that have gone through forced withdrawal, whether they've been supported by medication or not, that are not connected to care and not offered medication-assisted treatment as part of their care during incarceration are at incredibly high rates, at high risk for overdose and fatal overdose following reentry into the community. Looking at best practices and how best practices are applied to drug courts across the state. Ensuring that we've got linkage to care for individuals who are court involved, as well as their families, so that we are taking the opportunity for people who are mandated to treatment to receive the high level of care that they need, including care for their co-occurring disorders, and then looking at the potential to strengthen connections to and the role of public defenders in working with and supporting individuals who have substance use disorders that are incarcerated. Next slide. Manufacturing and trafficking. We've talked about HIDA already in our law enforcement agencies. Some of the issues that have come up and some of the gaps and recommendations that have been discussed pretty broadly are the collection and sharing of seizure data, as I had mentioned before. Understanding that multiple drugs within an investigation really do complicate how we understand what is occurring, and do also have implications for law enforcement's ability to reduce the drug supply. Not every drug that is actually confiscated is tested. And so the majority of drugs, unless they're being used actively for prosecution, do not undergo testing. And so we've got lots of information out there that we don't have access to because we really don't know what is in the substances that have been identified. We've also seen a huge increase in methamphetamine, and while it's not being produced in state, continues to be a major issue across our communities. And that there are supply and demand issues that are also driving different markets as it relates to illicit drugs. Next slide. Economic impacts. So we have a 1915I waiver that is still working its way through CMS that does provide reimbursement for supportive housing, but certainly housing as it relates to individuals who have substance use disorders, as well as those that are in recovery, remains a major gap. So ensuring that we've got housing first policies that are being put into place for housing programs, recognizing that individuals who are experiencing homelessness are at increased risk for substance use, as well as having substance use disorders and tailoring programs to meet their needs uniquely. Addressing the gaps for supportive housing, and then looking at the availability of affordable housing and other types of housing within our inventory to support individuals in their recovery. And additional considerations include the Justice Department guidance for the Americans with Disabilities Act and protections for people with opioid use disorder. Looking at the many assets and resources that we have, as I mentioned before, we have a lot of wonderful things happening in our state, just none of it really happening to scale. Engaging individuals with lived experience in programming design considerations. We've really prioritized making sure that those voices of individuals with lived experience are part of the design of programs from the very beginning. Linkage of care for individuals who are incarcerated, court involved, as well as for pregnant women with opioid use disorder is vitally important. Establishing bridge programs for MAT from emergency departments, recognizing that we've got a very brief period of time where an individual who has survived a non-fatal overdose or has sought care in an emergency room may be interested in engaging with medication-assisted treatment and enabling emergency departments to be able to prescribe and provide bridge prescribing until that individual can connect with a care provider. And then all of the issues as it relates to parity and doing the due diligence that I think we all want and need to see in the state as it relates to coverage and participation in a statewide hub and spoke model, and reducing some of the quantitative and non-quantitative limits that impact individuals and their ability to access care. And I think Crystal or Laura, that may be the last slide. Is that correct?
That's correct. Yes.
So Chair, I'll turn it over to you. I don't know where we are in timing and if we have opportunity for dialogue.
Well, thank you so much. And I can already see that there's a lot of great crossover with the gaps you identified. And I think the presentation that we're about to hear from, which I want to move to, and also future discussions in this working group. So for the sake of time, I'm going to go ahead and move on to our next agenda item so that we can get a chance to hear from Victoria Gonzalez in regards to the Nevada Sentencing Commission. Some of the things that you touched on, Dr. Woodard, has some crossover there. So I asked for a presentation because I used to serve on this committee a couple of years ago, and I know that a lot of that data has been something that has been collected. And then with the passage of AB 236, one of the major considerations of that legislation was to get better data collection, as well as recommendations for substance use disorder and interaction with the criminal justice system. So if I can pass that on to you, Victoria, if you can please take the mic and run with it. And I do want to remind us that our goal is to end by 4:30, and I'll go over the last few agenda items quickly.
Fantastic. Good afternoon, members of the committee and Assemblywoman. It's so great to see you. You said it's amazing. Actually, I just remembered now with the Sentencing Commission before, our paths have crossed so many different times: education, criminal justice, education, criminal justice. Here we are. And so it's a great honor to be working with you again. And so I look forward to our partnership and collaboration. So really quickly, yeah, my name is Victoria Gonzalez. I'm the Executive Director of the Nevada Department of Sentencing Policy. We are a newly created agency. We were created in 2019. The Nevada Sentencing Commission, as the Assemblywoman mentioned, was previously housed in the legislature. It has actually been through various iterations over the last 30 years. And its most current iteration is now in the executive branch, housed in our agency, where we offer them the full staff support that they never had before when they were housed in the legislature, because we can devote our full time to them and helping them make their data-driven recommendations. Generally speaking, the the statutory mandates for the commission are quite vast, but overall, we generalize them as we make data-driven recommendations for sentencing correction policies. I also boil that down to just criminal justice in general, because we are looking at everything leading up to sentencing, after sentencing, and then of course, while they're serving their time in the Department of Corrections. And that takes us to basically everything in the criminal justice system. And specifically what our agency does is we assist the Sentencing Commission in fulfilling their mandates, but we are very focused on facilitating the collection and aggregation of criminal justice data throughout this state. And that's from every criminal justice agency that we are working to try and get data from in order to help the Sentencing Commission in their mandates. Next slide, please. So as we've talked about, AB 236 is very relevant here. It is the Justice Reinvestment Initiative bill for our state. And so generally speaking, the policies that drive the Justice Reinvestment Initiative are you're reducing recidivism, slowing prison growth, and maintaining public safety all at the same time. When AB 236 was passed back in 2019, it specifically tasked the Sentencing Commission with tracking and assessing the outcomes from enactment of AB 236. So there are huge data mandates that are put on the Department of Corrections, the Division of Parole and Probation, the Central Repository to submit data to our commission so that they can evaluate how is AB 236 going. Also related to, or also tasked to the commission and AB 236 is the Sentencing Commission is required to make recommendations for funding to the Nevada Local Justice Reinvestment Coordinating Council, which was established in AB 236. That coordinating council does two things, which I'll talk about just down here in their mandates, but it's related to addressing those programming at the local level and addressing how is AB 236 going at the local level. That funding is supposed to come from changes in the prison population in terms of cost savings is what the driving policy behind Justice Reinvestment Initiative is. The idea is that as you drive the prison population down, you hope to realize a savings in correctional costs, which then can be allocated to those things that will continue to keep the prison population down and reduce recidivism. And that's where those recommendations from funding are supposed to come. As I said, AB 236 created the Nevada Local Justice Reinvestment Coordinating Council. This is part of typically other justice reinvestment initiatives in other states. Some of these councils are created like this to administer and have the same administer grants and have similar duties as our council does here. So the council is mandated to make recommendations to the Sentencing Commission regarding AB 236 at the local level, identify county level programs and treatment needs for persons involved in the criminal justice system, make recommendations to the Sentencing Commission regarding grants to local governments and oversee those grants, and then identify opportunities for collaborating with DHHS at the state and local level for treatment services and funding. And that's all in the statutory mandate of the Coordinating Council. Next slide, please. So the relevant activities, back one. So the relevant activities that are relevant to this subcommittee would be the Coordinating Council has been working to collect qualitative information about programming and treatment available in each county. So what we've done is we sent out a survey at their first meeting, which they had back in September, and asked them to bring us back some just baseline information, which is basically at the qualitative level. So it's not quantitative, it's not data, it's their anecdotal information they're able to collect from their stakeholders that they have in their county. And we're just getting some initial feedback about what is the general need, what are programs that you're aware of in your county that are available. What the Coordinating Council is working on right now is to make a request for an appropriation for what I am calling an upfront reinvestment to fund the grants administered by the Coordinating Council. So the Coordinating Council was established back in 2019 with AB 236. And again, I explained that that mandate of administering grants was supposed to be funded from the cost savings that could be realized from changes in the prison population. Well, AB 236 went into effect July 1 of 2020. The coronavirus hit and shut down our state in March of 2020. And so as we know, there have been various impacts to the criminal justice system. And one of those includes a decrease in our prison population. And so the Sentencing Commission is tasked with evaluating changes to how is AB 236 going. With the prison population, it's difficult to distinguish what the changes in population could be attributed to AB 236 versus what is attributed to the COVID and what the impacts are going to be from overall the prison population in general. So rather than trying to rely on a calculation that we can't quite distinguish, I am recommending that what our lawmakers do is make an upfront reinvestment into investment. And other states have done something similar to this to get their justice reinvestment off the ground, is to start funding grants and programs like these in advance of anticipating the outcomes from AB 236, which I think makes sense. As you see changes on one end, you need to kind of make sure everyone has the resources they have on the other end to make those things happen that will reduce recidivism and also maintain public safety. Next slide, please. And so again, aligning with what is important for this subcommittee would be those special populations. That would obviously be those who are involved in the criminal justice system and have those substance use needs and some mental health needs as well. And then also I thought was relevant for this subcommittee was that AB 236 specifically revised penalties related to certain drug crimes and other nonviolent crimes and changed the thresholds for those. And so with the vision of that, I think would be the policy behind that would be that those individuals can get the support and help they need rather than putting them through the criminal justice system. Look for alternatives to deal with other issues that could be underlying some of those and minimize the penalties that are related to that. And then AB 236 focuses treatment on behavioral health and substance use of persons. Again, that's an important part of the policy underlying how we're going to decrease the prison population, how we're going to keep it low, and then how we're going to reduce recidivism while maintaining public safety is addressing those needs. So the Sentencing Commission is tasked with collecting and analyzing data to evaluate programs and treatment along with the other data that they have. Next slide, please. The gaps that we've been able to identify, as Dr. Woodard talked about as well, are specific to collecting data. Again, what's important to this subcommittee is important to us as well as the Assemblywoman talked about is breaking down those silos and focusing on collaboration. I will say that the agencies who we are working with, so the Department of Corrections and the Division of Parole and Probation, it's difficult to share data across agencies. So I think when it comes to this, the issues relevant to this subcommittee would be how do we keep track of the continuity of services from something and treatment that someone's receiving while they're incarcerated to when they move to being supervised. And that is very difficult to keep going, believe it or not. So there's programming and treatment that could be received while someone's incarcerated, but by the time they get to supervision and trying to build their case plan and management while they're out there, it's very difficult for DOC to share that information with the Division of Parole and Probation in order to make sure you have that continuity of services and making sure that you're addressing the needs that have been identified in the various risk assessments that are applied throughout someone's experience of the criminal justice system. So
just a quick interjection there. Christine Jones Brady, for the record, Vice President of the Sentencing or Vice Chair of the Sentencing Commission. And I work for the AG. I'm on the Sentencing Commission on behalf of the Attorney General. The overlap between what you all are doing and what the Sentencing Commission is doing, as Ms. Gonzalez is reporting, is 100% true. The members of the Sentencing Commission, one of our fears or concerns is that with the passage of AB 236, the sentences were going to be reduced, people were going to be released, and yet there wasn't going to be the programs and services available to keep them from getting back into the system. And so when Ms. Gonzalez talks about asking for some upfront funding, that may overlap with some of what you're doing and also with some of what the Reinvestment Committee and the state plan has. So hopefully the Reinvestment Council and the state plan can connect so that if there are gaps, and there are gaps in services that have to do with either, treatment, housing is huge. There's not enough transitional housing programs, not enough places for people to go. People come out of prison. Where do they go? Do they go back into their family or their community where maybe they're tempted with more substance use, that sort of thing. So there is a lot from my viewpoint, there's a lot of overlap between what you all are doing and what the Sentencing Commission is trying to accomplish.
Thank you, Ms. Brady. And then I'll just jump ahead to our recommendations then is looking at is looking at what this subcommittee is tasked with is keeping track of those programs where funding is needed. We could really use input from you about what types of programs are out there. We're looking to gather that information now. This would help support the request for the appropriation to the coordinating council if we could identify specific programs that could be developed in these, especially the rural areas. I'm looking for dollar amounts that would just help give the lawmakers an idea of what would support a request for an appropriation. And then, of course, we know that this subcommittee and our agency and the commission would support any agency or program that would need help collecting data. And so we're always looking to close those gaps so that we have the best information to present to this group and to the commission and to the lawmakers when it comes to deciding where are your dollars best being put to work. So I think the rest of the information is on my slides. Is there anything else on, if I can see the next slide, I can't. And then there's my contact information. So it's perfect timing. And so, of course, I'm looking forward to working with you and partnering, and appreciate what Dr. Woodard front loaded for this information as well. I can see we're going to work, and thank you to Ms. Brady for identifying those overlaps where I see a true partnership here for all of us. So thank you very much for your time.
Thank you so much. And Dr. Woodard, I see your hand raised. Did you want to add to that?
I wanted to thank you for the presentation and also welcome the opportunity to collaborate. I do think that it's something that we've needed to do for a while. I know COVID had put a lot of those plans on hold, but there is a lot of synergy there between what the Sentencing Commission is doing and what we're already doing. So looking forward to continuing to share that information with you.
Wonderful, thank you. And let me just say that you always have a standing invitation to join the subcommittee discussion, and I'm sure we'll be having you back for future presentations and collaboration as subject matter experts and as partners in this work. So always appreciate the opportunity to see both you, Victoria Gonzalez, and Christine Jones Brady. Thank you for being a part of this, and also know that we have some opportunities maybe for future presentations on some of the requests that you just mentioned in regards to some recommendations moving forward. So thank you so much. I'm going to go ahead and move on to our last few items here as we wrap up our time together. And I do anticipate that we'll be able to jump into the subject matter expert presentations and discussion a little bit more quickly in future meetings. This first one, I tried to leave a little bit more open at the beginning so we could get a chance to dive deeper into member introductions and set the course for where we're headed. So if I can move into agenda item number 7, and that's recommendations for presentations from subject matter experts. And I'll just let you know that if I can take a prerogative as the chair, some of my vision for this in line with our duties and roles as a subcommittee is to bring in the future, to bring in presentations from law enforcement and the various jurisdictions to have an idea of, from the ground level perspective, what are some of the trends that they're seeing, any data that they're collecting, and some of the needs and recommendations that they've identified. And then to hear from healthcare, hospitals and emergency rooms oftentimes are our first line of defense. At some point in the future, I'd like to bring some presentations in that regard. Issues regarding families and children in the welfare system and some of our partners who work in that space. Education and K through 12, again, understanding what some of the needs are and recommendations. Marginalized populations, our tribal communities, as well as our BIPOC communities, to see if there's some things that we need to be keeping in the back of our mind, asking the right questions as we look at each of these aspects of response. And then city and community and counties. Certainly many of our counties and many of our cities are tackling issues around homelessness or economic impact, public health and safety issues that we're seeing in some of our more urban areas, as well as some of the needs in the rural areas that may be hidden to those outside of the rural communities. And so what I'd like to request from this committee is if you have recommendations for subject matter experts or presentations that you would like to hear or that you think that we should be hearing as a group, will you please email Crystal Duarte and let her know what those contacts are, and we'll be gathering those and laying out a map for which themes we want to address in future meetings. And then also, if you have anything that's a priority that you think we need to hear sooner rather than later, knowing that we do have some deadlines to meet in terms of initial recommendations. So for the sake of time, I'm going to leave it with, please email your recommendations. And if you have any questions, and then I'm going to move on to item number 8, which is our next meeting. And we had identified 2 possible meeting dates, May 9th or May 17th. And thank you for those of you who were able to respond with your availability. It looks like May 9th is going to be the one that works best for everyone in order to meet a quorum. So we will have our next meeting as a subcommittee on May 9th from 12:30 to 2. And again, by that subcommittee meeting, please have any reading done ahead of time that we'll send out, as well as please submit your recommendations for subject matter experts before then. And then moving on to our last agenda item before we adjourn is number 9, public comment. And I'll open it up for if we have any public comment, limiting it to 3 minutes. I know that we're already somewhat over time. If you can raise your hand if you're on the Zoom call, if you want to make any public comment. And I do not see anybody. And then do we have anybody that's on the phone who might have called in? Crystal or Laura, do we have anyone else who's tried to give public comment?
I don't see anybody that's only joined by phone, no.
Okay, great, thank you. All right, well, seeing no public comment, thank you all for a great first meeting, and we'll continue to get even more efficient at these. And don't hesitate to reach out to me if you have some more thoughts or discussion, and then certainly send your recommendations into Crystal. With that, we are adjourned.